Thank you. So the topic has actually been changing over a while. So we are talking about tailoring TAVI to secure lifetime management. This is a sponsored session by Boston Scientific. However, I made my slides myself. So first I will talk about how to use Accurate Neo2, and then I will go over cases. So how to do the case is very simple and very usual to do Accurate Neo, just similar to any other self-expandable valve. You will get your secondary access, which could be radial or femoral, and then you will get venous access, which we would use usually for a pacemaker. Usually the pacemaker would be used for ballooning, as well as to keep a pacer if the patient needed pacing after the procedure itself. You will get your primary access, and usually you're going to pre-close it. Usual access is right femoral, and we use two pre-closes for this. And then you deliver the big sheath. The big sheath here is Boston sheath, the eye sleeve. For those who do Sabian, it's very similar to the Sabian sheath. It's a very good sheath, to be honest. I wish Boston decided at one point to sell it by itself, so we could use it for some structural cases. The centers where they do a lot of Boston, they keep those sheaths for different uses later on. So it's a very, very good sheath. It's expanded, so it's a 14 that can go up to 17 French, and it expands by itself once you deliver a bigger material in it, and doesn't bleed badly when you remove it. It's even better than some of the features in the E-sheath. Then you put the valve itself, and you put it at 6 o'clock, and that's going to achieve alignment in most of the cases. And if not, you can adjust that as well. Then you deliver the valve, the dot, the nadir of the non-coronary leaflet or the annulus, and then you can see it here that the dot is in the lower end of the non-coronary cusp. And then the first operator gonna be just keeping the valve in place. The second operator will turn knob 1, and at that point, to be honest, when I was learning the Boston valve, I was wondering why they are taking, the opposite, complete opposite from every other self-expandable valve, why they are taking upper to down, and why not the other way around, and how come we are not needing pacing as well. So if you look here from the top-down deployment in the top right, that the valve is opening, and while the valve is opening, is not obstructing the output of the heart. The valve is still functioning, and there is still patients still have complete output. So the valve is not moving, and at the same time you have output. So you have full hemodynamic stability for the whole time. So you have time to position your valve, and you have time. So here the valve is open, full knob open, and it's not moving. And the final one is you just deploy the valve, and the valve is very stable and it doesn't move from its place. While if you do a self-expanding other valve where it's bottom up, if you are doing it without pacing, as in this case, you will see that the valve will have a lot of, especially if the LV function is normal, you will have a lot of rocking movement because the valve is obstructing the outlet of the heart. So it's trying to get the valve outside the outlet. So at that point, the first operator completely just keeping a neutral tension. The second operator is turned knob 1. And then the second operator continued to maintain position, where the second operator just turned the second knob after removing the safety button. Very simple. You just remove it just like you remove any other self-expandable valve. And then you reverse whatever you've been doing. You rotate knob 2, then rotate knob 1, then you remove the valve itself. Then you take pictures just like the usual thing. So I will start with the cases here. I had two interesting cases to discuss here very quickly. So Mrs. M actually being referred to me by cardiovascular surgeon. She's 62 years old lady. She does have diabetes, hypertension, obstructive sleep apnea. She had cosmal breathing while she's actually sleeping in the cath lab. She's asthmatic. She's morbidly obese. She's 150 kg, 150 centimeter. Her BMI is around 57. She's a very, very obese lady. So she was referred to me with this new shortness breath, progressive, and was finding suggestive of severe aortic stenosis. She was actually 59 when she was discovering to have severe aortic stenosis. The surgeon been dodging her for a couple of years because of her comorbidities, and finally she was referred to me. Her echo, simple, it's severe aortic stenosis, and it's obvious here the valve is not opening very well as well. Again, her CT parameter was done. Her parameter is 66. Even this is a generous 66. It's smaller than 66, to be honest. The area is a 373. The area-derived parameter is 20 or 21. Sinuses are quite tight as well. Is a 24, 25, 25. And the coronaries, our height is fine. It's 11.8 and 19 for the right. The STJ is quite wide as well. It's as similar as the annulus. Nothing, it's not tapering. It's just like a continuation of a tube. Femorals are fine. It's 8.4, 8.2 for the light femoral. However, if you look at the abdomen, the distance between the femoral to the abdomen wall is huge. The distance, row distance, is 21 centimeter from skin to skin. And we had difficulties getting the access, as you can see. So if you do valve selection for this lady, I use the TAVI sizing app. You would end up, if you're gonna need either 23 Medtronic valve or 26, we're gonna go for a self-expandable, for sure, supraannular valve for this lady, given her high BMI and the risk of PPM. So we didn't even thought about balloon expandable here. So self-expandable supraannular valve, we have two options, the Boston and the Medtronic. And for the Medtronic valve, you're gonna end up using either 23 or 26. The 26, she is not fit, given her sinuses are quite tight, being less than 27. And the 23 is, to be honest, not that sizable, giving her, it's only 9.5 in the lower limits, and she's not very heavily calcified, so we elected to go with the Boston valve. And I still remember I had Proctor for this case, since it was one of the first few cases I have done for Boston, and I was insisting to go for a medium valve. I was telling them, guys, this is crazy. Look at the lady. She doesn't look small by any means. So let's go medium. They say, no, just trust the valve, go small. And we picked a small valve. So they trying to tell us in multiple studies, they have a single-digit gradient in their valve in most of the studies. And this is quite good. So we decided we're going to use a small accurate new valve, deployed 7 millimeter below the annulus as advised. And as you can see here, this is one of the most difficult cases to get access in my whole, to be honest, career. I usually get omnious when I get more than 2 pricks for the femoral. Here I have 3 pricks and I got twice a vein, even though I do all my access ultrasound guided. I don't even get to the femorals without ultrasound. I just cannot get into the artery, and I got to the artery at least 10 times, and because the patient take a deep breath, the needle will jump out completely. It will not, like all the needle is inside, and then the patient will take a deep breath and the needle will come out of the leg because of the size of the patient. And here I am inside the artery, but it's a low puncture. Here is my hand getting radiated. Not the best practice, but you can see that I am at the level of the bifurcation as well. Here I don't like my position, so I ended up getting another sheath inside the right side. This is not a common practice by me, I swear, but this is what happened. I'm showing it to you. So here you can see I'm getting the coplanar image showing the 3 sinuses, cross the valve, very simple here, delivering the valve at the nadir of the lower coronary, non-coronary cusp, opening the valve itself, sorry, yeah, opening the knob 1, and this is completely knob 1 now is open, and the arc is stabled at the arch. At this level, as you can see, this is not based, there is nothing being done, and the valve is extremely stable, and the patient's hemodynamically stable. You have time to position the valve itself, you have all the time, and the patient is extremely stable at this point. And then we deliver the valve, and you just reverse the maneuver by putting knob 2, then knob 1, and you close the valve, and you just do the regular check for paravalvular leak and check for the gradient. Then we removed our big sheath and we put small sheath, and because we had so many sheath, actually we could actually check from the same side this time, and we checked it, and there is no, like just a small stenosis, but no harm being done with all the puncture that have been done by myself. Now, the amazing thing after the case, the gradient is only 5 after this case. And I still see her after a year, and her gradient is still mean gradient of 5, 6 multiple times. And I'm amazed, to be honest, with the hemodynamics that this valve deliver, given the size of the patient. She's now going for a sleeve surgery. Hopefully that's going to help with her morbid obesity as well as other diseases.
Dr. Ahmad, can we take a minute just before the second case,
Sure.
just to keep the thought process?
Yep.
Great case. You just showed elegantly how you really, a modern TAVR operator should analyze CT in relation to younger patients for lifetime management. You presented 3 platforms. You could have even added another platform, which is the Aviator for Abbott, to see whether or not which one you would choose out of those platforms. Younger patient, small annulus, you calculated your EAO, and based on that you proceeded. The amazing part about when you are dealing with bigger patient is sometimes you would like to end up with a smaller gradient, but it's not all the time. In this case, you nicely end up with a single-digit gradient. The second comment I would like is the deployment. Throughout, for all of us who use Accurate Neo, the deployment has no hemodynamic compromise. I will leave it to Dr. Talal also for any comment about the first case.
Beautiful demonstration. Actually just show us how easy it is actually to use this valve. Although it's a self-expanding valve, it just appears as a balloon expandable valve, very fast, very predictable. This is, I mean, the case they just show us, it's a very common scenario in our region. We get these cases all the time, like younger women, morbidly obese, high PMI, she has small annulus, small valve. You cannot use a balloon expandable valve because of patient prosthesis mismatch. So always when we get this patient, your thinking is you want to use a device that has that provided with the longest durability, and this could be achieved by supraannular device that provide with reduced gradient, better hemodynamics. Important things also is when you have these relatively young patients, you want to also use the device that has lower pacemaker, good coronary access, provided with good coronary access in the future, because they have longer life expectancy. So I think this is the valve that I would choose in this case as well. I totally agree with you.
Yeah, well, she had a lot of risk factors for coronary artery disease, and given the narrow STJ, narrow aorta as well, we were worried that putting another supraannular valve, we could have difficulties getting to the coronaries, and she has a lot of risk for coronary disease given her comorbidities. So we'll start with the second case. She's a 70-year-old lady. She is referred to me from another surgeon as well, and she was declined by a TAVR from another center. And it does have a perspective. You know, all my cases are like this, declined by so many people, and they end up with me. But You have to start somewhere at some point. This is when the program started, and we had to, we were gathering cases. We are happy to announce that we actually completed 130 cases in a year and a few months, so our program is growing nicely. So 70 years old lady, referred from another surgeon, declined by the center. She's diabetic hypertensive. She does have a breast CA with radiation, and her annulus is 350. Her perimeter is 66.9, and her sinuses are not bad, 25, 26, 26.7. Her STJ is 66. Her coronaries are 7.7 millimeter. However, an underestimation of the left coronary artery is 15 millimeter. So the STJ at 13 millimeter. So if you think about it, you will push the leaflet, which is not bulky, so you would stretch it toward the STJ, and it should obliterate the coronaries completely, causing coronary obstruction for this patient. And her perimeter here is 83. So for this patient, we had two options, to be honest. Either we used a balloon expandable valve, and you go 3 or 4 millimeter below the annulus to deploy below the STJ, and hopefully have enough space between the STJ, as you can see here, between the valve and the STJ here. And you mark there as well, it's going to be 1.6 millimeter in the left side. You can see between the valve, which is the not STJ VTC kind of thing, which could be occupied by the valve itself. So what's Boston would actually advertise that you have you have good coronary access. And what I was interested is in the lower right side of the page is upper crown cross-native leaflet. So open and it's actually compress the leaflets of the patients behind the valve itself. So it's control the valve leaflets, keeping it in place, preventing it from obstructing the leaflet coronaries. So we started the case as a usual case. The patient's very thin, access was easy. We put the sheath, we took our picture, and you can see here the coronaries looks scary low. We get into the valve. We were happy about the pigtail here. I don't know why we're taking so many pictures here, but we were happy about the RSMAI here. And then to be honest, also I spoke with the proctor before starting this case, because this was also one of the first few cases for, and he was saying there is no need to protect the coronaries, but I'm too chicken to do it without protection, so I kept a wire, that's it, inside the coronaries without putting a stent. And we ballooned the valve, and you can see here the LV function is good. It's actually moving, even though it's based, and I want to, attract your attention to this, that the balloon is moving even though I'm pacing. And then we delivered the valve. This is a very long scene, I'm gonna skip it. And then we get aligned the valve here correctly. Here it was completely malaligned. So we aligned it, we rotated, kept rotating it till we were happy about the alignment, because in this patient, it would be very important to get aligned with the coronaries, given the low coronaries, as well as this patient does have a very calcified disease in the LAD, and we were worried about to treat it, given her gradient before the procedure was 75, and she might need a rotablation. So we ended up aligning the valve very well. The valve was situated at the lower nadir of the non-coronary sinus. Open the crown, just simply. This is knob 1 completely opened. Then the valve was deployed. And the final image is that you have a very good access to the coronaries. You can get the coronary access very nicely here. And the leaflets, you can see it entrapped between the anchors of the valve itself. And yeah, as you can see it here, between the valve and where it's originating from and below the leaflet coronary. And as you can see, there is a 90% LAD lesion, mid-LAD lesion. This would also give you trouble if you try to pace the patient during self-expandable valve or balloon expandable valve, as the patient might go into VT with a severe lesion. And we actually treated later on with a rotablation with no problem, because we could get into the coronaries very easily. The final shot looks nice. There's no problems, no disease at all. And we kept following the patient. The coronaries was fine, the gradient was fine. So what this valve tried to promise is precise positioning. It's not a problem. The device actually doesn't move while positioning the device. Quite simple, 2 knobs. You deliver the first knob, then the second knob, and then you deliver it. And no annular flow restriction during the deployment for knob 1, and the knob 2 happen over a second. That's why you don't have to pace it. And this is not from Boston by themselves, but from me. If you want to do, like, they stress in doing knob 2 very quickly, just to get rid of, because the patient is not being paced. If you're not comfortable with this, just pace the patient for a few seconds while doing knob 2, then it could be done much easier way. The deployment time is 3.9 minutes, and predictable alignment for the patient. You could actually align it for 100% of the patient, given that the left coronary artery is coming from the coronary cusp. You can predict it 100% for the patient. PVL, I think it's deliver whatever the good valve in the market deliver, nothing extra, nothing less, comparing to the others, and this is proven by studies. And as well as single-digit gradient for any supravalvular valve, it's delivered the same results, except the risk of a pacemaker is less than any other self-expandable valve. And keeping in mind, you don't have to target the 1 to 2 millimeter below the annulus like the other self-expandable valve. You can actually deploy it 6 millimeter, just easy, without thinking about it, below the annulus, and you still gonna get free of pacemaker. All the cases that we have done, to be honest, so far, with no pacemaker risk so far. Thank you.